Hello, Maduka.
Yeah, you started.
Let me
Good
just
evening,
a few
everyone.
minutes.
Okay, go ahead. Maybe after you then. I'm having
Oh,
issues with network, so I'm just struggling to present and
okay, sorry.
okay, when you're through then. Sorry.
Since Madoka
Okay.
is having issues with network, this one that he's clearer. Maybe we can take it soon.
Me, I'm feeling sleepy. Oh,
Okay, Neka, go ahead.
thank you. So I'll be
Um,
brief because there's no question actually with my own. There's no question. They just said it an ECG tracing. What's the next line of management? So depending on
um,
what is presented, I don't know, that's what you use to manage. Usually the exercise ECG tracing is indicated for those who have intermediate risk of development of coronary artery disease. And this intermediate risk is actually calculated. You can either calculate it using traditional risk factors where you use the presenting symptom of the patient, if the like the angina pain, if it's typical or atypical, and then use the patient's gender to there's a board sort of that you can trace the risk the patient has. If the patient usually presents less than 15% of that scoring system, you know the patient has a low risk. For those, you don't actually do um, the stress testing for them. But if you do the probability scoring and the patient has 15 to 75%, that's the intermediate risk that you go ahead to do your stress test. But if it's above 75%, then you go straight ahead to coronary angiography. Apart from using the traditional risk tables, there are other um, scoring systems like I think those are the ones they use if I'm not mistaken, the coronary artery disease consortium and some other parameters to do the pretest probability for coronary artery disease. So when the patient meets the criteria, you go ahead to do the stress testing. Of course, you take your history. Most important in the history before stress testing is history of the biodata first, and then history of risk factors the patient has, diabetes, dyslipidemia, and other normal traditional risk factors for coronary artery disease, smoking, and maybe a family history of coronary artery disease. Then you take history of medications the patient is on, knowing very well that being on certain medications like digoxin can alter the picture of what you're looking at. And then you take history of other comorbidities the patient is being managed for. You quickly check the patient's vitals before starting the procedure, and then you do a rest ECG. So you see what it is on rest before you start putting the patient on the machine. Then you counsel the patient. Of course, you take your consent. You ensure that all you need to prevent to prevent or manage complications that may arise are available. So from the machine, you ensure there is no water on the floor. You ensure that the machine has rails. You ensure to teach the patient about the stop buttons of the machine in case of chest pain or they get tired. A fitted shoe when doing the procedure. Then the question now says, when you're doing it, what is the next line of management? So depending on what you see on the tracing as you're doing the ECG, now you use different protocols do the testing. There's the commonly used one, the Bruce protocols, which usually has 7 steps, where you start at the speed of 1.7 and then increase the speed of the stressing every 3 minutes until you get through to the 7 stages, if the patient is able to, and then thereafter you enter the recovery. But there are some things that would make you stop the decision halfway, or when you have a positive result. So the common one is the planar or downsloping ST segment depression that prolongs about 60 to 80 milliseconds after the J point. And then we have other positive results like presence of ST segment elevation 1 millimeter, presence of ventricular arrhythmias or poor response of blood pressure when the blood pressure is going down following stress. This is a positive result. So I'm assuming if any of the things you see on the ECG suggests a positive result, what do you do? So immediately you get a positive result, you stop the stress the machine, and then when you stop, you first assess the symptoms. So you ask the patient, take just a very short history. How is the chest pain, the character of the pain, any dyspnea, and then you quickly check the patient's blood pressure at that moment, see if it's low or if it's severely elevated. And then you ensure that the ECG, the ECG leads are already on the chest. When you stop the stress machine, you don't take out the lead. So you still ensure that the ECG leads is monitoring so you can see any events that is occurring post procedure. Then at that point, if it's a positive result or suspicion of a positive result, our patient has maybe symptoms to support, you may consider giving the patient sublingual glyceryl trinitrate at that moment if blood pressure is stable enough. Or also, you can also give the patient aspirin and metoprolol, that aspirin and a beta blocker as well. While you do this, you contact the catheterization lab and send the patient for urgent angiography. So that's the steps you're expected to take when, if you find out that the result is actually positive. However, if the result is not conclusive, in that maybe you don't have the typical positive signs, or patient has symptoms, but you don't have the typical ECG changes to support, you may go ahead to do further testing to test myocardial viability, which would include doing any of your perfusion scans like your PET and SPECT scans. However, if patient is low risk, all you have to do is apply the ABCD management, where you counsel the patient to abstain from the A is ACE inhibitors, control blood pressure if the patient is hypertensive, using ACE inhibitors or beta blockers. Then you encourage patients to stop smoking, you counsel on dietary management, control blood sugar, and then encourage patients to continue exercise at home and continue patient monitoring. Thank you.
Okay, thank you so much. Thank you so much, Dr. Onelum, for taking your part. Okay, so the floor is open to questions and contributions. Thank you.
Okay, can I just add? Thank you, Dr. Onelum, for the beautiful presentation. Just to add on response to stress testing, that there are normal responses and abnormal responses that can come, and we can see that kind of question in MCQs. Usually you will expect an increase in the heart rate, right? And that's normal, but it's abnormal if you're not able to get a heart rate above 120, or if the heart rate does not get, or the patient is unable to attain like 85% of the predicted maximum minus the age will increase normally, and then the cardiac output, yes, heart rates increase, but it's abnormal when you now have like a drop in systolic blood pressure. So what you expect should actually be an increase, not a drop. And then so generally the things that would increase the heart rate is normal for it to increase. The blood pressure is also normal, the cardiac output, and then the oxygen consumption would increase. But the total peripheral resistance is expected to decrease. Okay. Then, but you have an abnormal response if it is a failure of the heart rate to get to an absolute value of like 120, or the person doesn't attain like 85% of the maximum predicted heart rate. And then it's also abnormal if you have a drop in the systolic blood pressure, or if you have marked hypertension, maybe you're now getting the range of over 220, over 110. And then the other aspect is in terms of their symptoms. So if you have a sudden onset of severe chest pain with an unusual onset of difficulty in breathing, that is also abnormal to see in the test. So just thought to add that. Thank you.
Thank you so much,
Thank you.
Dr. Sibi.
Thank you.
Okay. I don't know if we have any more questions or contributions. Okay. We'll move over to our chiefs in the house. Thank you so much, Dr. Nelu.
Hello, Dr. Mega. Hello. Hello, Dr. Nelu.
Yes, sir.
Yes. Is it possible for you to drop on the platform any of those screening tools we use to stratify the patient into low risk, intermediate, or high risk?
Okay. And because I keep forgetting them. Yes.
Thank
Okay.
you. Thank you.
Yeah.
Okay. Okay. I'd like to move over to our chiefs in the house for their contributions and suggestions. Thank you.
Thank you, Dr. Meka. Good evening, everyone. I don't think I have more to say. First ECG, we've discussed it before, actually. And the points, we should just note the things that you said as regards things that can affect reading of the stress ECG for MCQ's sake. Then, yes, you talked about medications patients, but I don't know if you mentioned Chelsea, but I'm not sure I had beta blocker, because patients is also meant to stop beta blocker prior to, understand, I use other antihypertensives, but beta blockers might stop the day of stress ECG. Then remember that we've gone through new guideline for chronic coronary syndrome. And just like Dr. Conte said last time, you should note that stress ECG might not really be appropriate for intermediate risk again from the new guideline. So we should just take note of that. And what else was I going to mention? I think that's all. Then, yes, the different, well, it might not be hard anyway. Different blood pressure and stress ECG, is it the normal? We use oscillatory BP machine, not the regular mercury, because of motion and movement of the MCQ. We should just, I think that's about all. Then also there's different how will I say now, the different protocols that we have. The ones we commonly use is the Bruce, but other ones. So you should know other ones and the peculiarities of the others. You can just briefly check that off. Then the METs at each stage, that comes out in MCQ too. The METs at this stage, especially for both protocol. Let's just try and check it up. Thank you.
Okay, thank you so much, Chief Moladi. Okay, Chief Adeyanju.
Thank you.
Okay, so in the chat room, Dr. Sample says, let's not forget other indications. Okay, sorry, Chief. Okay, you can have the floor, Chief. Sorry.
I'm sorry, I was trying to unmute myself. Good evening, everyone.
Good evening,
Thank
Chief.
you, Dr. Onelum, for your presentation. Please, I want to encourage us. Let's try and look at the ECG tracing, that is stress ECG. So, area where the ECG is then like on aspect, let's try and remember the indications. What will make you stress ECG? What are the appropriate responses when you are doing stress ECG? The increased SBP to how much? The increased heart rate to how much? 85% of MPHR, diastolic BP to how much? So let's note all those percentages. Then Dr. Moladi has already mentioned the protocols. Let's also know the protocols and the stages. Bruce protocol, common ones in our minds course. How many minutes per staging? Top is already mentioned. Possible. Let's just on you arise with it. In our various centers. Thank you. Hello, Dr. Florence. Am I still audible?
Okay, you were in and out. You were
Sorry.
fluctuating.
A
But
call came in,
yeah,
but I don't know whether you can hear me now.
I can hear you very
Sorry.
well now.
What was the last thing you heard? I was talking about what? Did I just know?
Okay, no, you were talking about the tools like the Bruce protocol. You should know they modify them. Yeah,
Yes,
Bruce
and
and
the
all.
staging too. And I was just trying to say that we should try and look at the YouTube of this procedure in case if it is not done in our centers. In case if it comes out, it may not come out. Then let's note the ECG tracing too, in case if it comes out as part of the ECGs or picture tests that they will bring for us. Thank you very much.
Okay, thank you so much, Chief. Okay, so on the chat room, they're saying let's not forget other indications of TST, like assessment of functional capacity, diagnosis of exercise-induced arrhythmias, assessing valvular abnormalities like AO. Then also for the standard Bruce protocol, for the stage 1, we have 1.7 mph at 10%. Then for the 5 METs, we have stage 2. Okay, so at 10% is 5 METs. Then stage 2, we have 2.5 mph at 12%. That's equivalent to 7 mets. Then stage 3 is equivalent to 3.4 mph at 14%, and that's equivalent to 9 mets. Thank you very much, Dr. Laliko and Dr. Sambo, for your add-ons. Thank you. We appreciate. Okay, so in the absence of further questions,
which Bruce protocol is this one that is only 3? Dr. Laliko, is there a new protocol? The standard Bruce should be 7. Then the modified one, I think, I'm not sure. I think it's just two stages.
I'll double check it.
Thank you.
Okay, thank you so much. Thank you so much, everyone, for your contributions. Okay, Dr. Maduka, please, are you ready to take your part now?
Okay, yes.
Okay, thank you. So you can have the floor. Yes, you can have the floor now. Thank you. Yes, you
can. Also change or when there is a cardiac injury. And these changes are also mediated by a neurohormone. Now, physiologic cardiac.
The stuff that's divided into physiologic and pathologic.
Hello.
Yeah, please.
I'm sorry.
Okay, we stopped at physiologic and pathologic remodeling, so maybe you can proceed from there.
Okay. All right, so there's physiologic and pathologic remodeling. When you talk of the physiologic remodeling, it just has to do with those changes, okay, the changes which could be structural or functional that occurs usually following physiologic changes in the body. And these physiologic changes could be due to exercise or pregnancy. For instance, we all know about the athlete heart. That's an example of a physiologic remodeling. And the physiologic remodeling is also called compensatory, it's also called adaptive remodeling. Now, for the pathologic remodeling, it's also known as maladaptive remodeling. And there are structural changes also that occurs following either pressure overload, level, or level ventricular volume of cardiac that and new. Now, a little part of a pathologic basis of the pathogen, which we all know has affectation vasculature as well as on the kidney. So for the for this cardiac remodeling we are discussing, what is of importance to us is the sympathetic affectation to the kidneys. So when this happens, there is activation of the renin-angiotensin-aldosterone system, where angiotensinogen is converted to angiotensin 1 by the renin, and angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. This angiotensin 2 that is produced has basically two effects. One is that it causes efferent constriction of efferent arterioles, and then also causes elaboration or increased production of aldosterone. Now, at this point, there are cytokines that are usually released, which includes interleukin 1, 2, and 6, as well as tumor necrosis factor. But for transforming reduced matrix proteinases. And so once this happens, it encourages laying down of collagen on the heart muscles, leading to this remodeling. Now, further discussing this remodeling, we may want to look at it based on the structural and functional changes, as well as cellular and molecular changes. Now, when we talk about the structural modeling, which are three. So the first is remodeling that occurs as a result of pressure overload, where, as we all are aware of, usually when there is pressure overload due to maybe hypertension or aortic stenosis, it leads to some form of it leads to concentric remodeling, whereby there are changes in the left ventricular mass that occurs with increased relative thickness. So it may progress to concentric hypertrophy. And so what usually happens in this type is that the sarcomeric proteins that are laid down in parallels to each other, so causing concentric hypertrophy. The next morphologic pattern is one that occurs due to left ventricular volume overload. Okay, so when there is left ventricular volume overload, there is usually the impacted area, okay, usually have left ventricular volume changes. And these changes translate to changes that occur in left ventricular pressure and volume at the other normal cardiac parts or cardiac muscles. So these changes now lead to a mixture of both eccentric and concentric hypertrophy that occurs depending on the particular part that is overwhelming. Okay, so these changes that occur that I've talked about has a way of affecting the diastolic and or systolic function of the heart. And so by so doing, we affect the general function of the cardiac myocytes. So that's it about the structural and the functional changes. So when we look at the cellular or molecular changes that occur, for the cellular changes, we're all aware that for remodeling, usually there are myocyte hypertrophy that occurs, and there is also myocyte loss. Okay, and then this myocyte loss is said to be as a result of apoptosis and or necrosis that occurs. Also, there's also fibroblast proliferation and fibrosis. So these are the things that occur at the cellular level. And then when we look at the molecular level, there's usually alteration in the abundance, function, or isoform of proteins involved in cellular growth, uh, 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 excitation, contraction, coupling, as well as cardiac energetics. So these are the things that are involved when we discuss cardiac remodeling. It is also instructive to note that the um, uh, methods that are used, okay, in managing patients who have cardiac injuries vis-a-vis heart failure, they are usually aimed towards reversing this remodeling. So if we throw our minds back to the pathophysiology where we talked about angiotensin 2 and aldosterone, we all agree that there are drugs that are available that block these pathways, and then by so doing is able to reverse these remodeling. And so these are also backed by studies. For instance, when we think of the solved investigation study, where it looked at patients and that were placed on enalapril for a long time. So it says that in patients with heart failure with reduced ejection fraction, chronic ACE inhibitors, in this case, enalapril, okay, was shown to prevent progressive left ventricular dilatation and systolic dysfunction. And these effects probably result from a combination of altered remodeling and sustained reduction in preload and afterload. Also, if we also cast our mind back to the MADIT CROT study, which also shows that a combination of implantable cardioverter defibrillator in combination with cardiac resynchronization therapy in patients that meet the criteria, okay, is being shown to not only reduce mortality, but also causes or reverses the remodeling that takes place in them.
Time up.
So this is essentially what I have to say about this. Thank you very much. I welcome inputs and contributions, as well as questions. Thank you.
Okay, thank you so much, Dr. Maduka, for taking your part. Okay, so the floor is open to questions and contributions.
Hello, Dr. Maduka. Thank you very much.
Thank you, Dr. Maduka, for the presentation. Can you hear me?
Yes, I can hear you.
Okay. So is it just these two treatment modalities that have been shown to alter the course of cardiac remodeling? Just wanted to know. The ACE inhibitors, probably ARBs too, since
Also use of aldosterone also, because you recall that at the point where there is increased production of aldosterone, aldosterone leads to increased elaboration of transforming growth factor beta, which produces which causes laying down of collagen fibers or collagen on the heart muscles due to reduction in matrix metalloproteinesis. So essentially, apart from the use of ACE inhibitors, okay, it's not just for enalapril also. Even by extension, even the ARBs, valsartan, spironolactone, that's the mineralocorticoid inhibitor, as well as the CROT ICD combination that I talked about. So these are the ones I'm aware of that help in reversing remodeling.
Okay.
Yeah, hello.
Oh, I don't know if beta blockers would have that effect as sympathetic activation. I think in hello, Dr. Somehow the sympathetic overdrive in the setting of heart failure also, that is when the norepinephrine accumulates due to the downregulation of their receptors. They still have this effect in elaboration of cytokines. So I don't know if by assumption they might be effective in also altering left ventricular remodeling as well.
Yes, looking at the
Yeah.
pathophysiology, I think I will agree with you, but I just mentioned what so
Thank you. Then please, that's a mixed concentric and eccentric. Please, can you, I didn't understand it. Is it that the infected area will have concentric and maybe another location will have eccentric? I don't understand that having the combination of eccentric and concentric, how you go about the measurements, because these are things we assess on echo. So how would we know that there's a mixture?
Drive the guy around.
okay. What I explained is that when there is an injury to a particular part, that is, this one is now localized. Okay, in this case, myocardial infarction. That area, okay, the muscles around that area has left ventricular volume changes that occur just for that area. And so by extension, because of that particular part that is not, will I say, is not in synergy with other parts of the heart muscles, okay, it now causes various volume affect the normal myocytes, okay. Now, depending on which is overwhelming, comparing, as in looking at the volume and pressure. So if in this setting, this patient is having more of volume change in it. Do you understand?
Okay.
But if the patient is having more of a pressure change affecting it due to the local injury that has happened in one part of the myocyte, okay, the patient will now likely present with a concentric pattern of remodeling. So in essence, it could be any of the two. So it could be
okay.
Yes, that's what I mean.
Thank you. Then lastly, I'm sorry. Lastly, the pathologic remote
Yes,
pressure volume and
the
mixed.
third one. Yes, the third one, the cardiac come from
So the cardiac injury is the pathologic basis, but the classification is it cardiac injury or mixed type?
No, the cardiac injury
yes.
There's a pathologic modeling. Now, if you want to discuss it based on structure and function, okay, you're now looking at the morphologic patterns. So it could be looked at as those the remodeling that is caused strictly only left ventricular volume overload. Okay. Or the remodeling that is caused strictly by left ventricular pressure is affecting the whole muscle, as it were. The same with pressure overload, which is affecting the whole muscle, as it were. That is for hypertension. So hypertension does not select one part of the cardiac, one part of the heart, or how do I put it? Same with aortic stenosis. But when you look at the third type, okay, there is usually the two occurring at the same time, both pressure and volume overload. So in this particular type, it is a localized injury, which you find in myocardial infarction. Now, the picture you now see, maybe when you do your echo or, with time, depends on the predominant hemodynamic change. Making sense. So for the local myocardial infarction, the two play a role together. But what now and depends on if the patient is having more of a volume overload problem or more of a pressure overload. But occur at the same time. I don't know whether I've been able to drive from this point.
Yes.
Yes, thank you. Yes.
Okay, thank you so much, everyone, for your contributions. So move over to our chiefs. Thank you, Tuka.
Thank you, Dr. Madika, for your presentation. The question on whether the drugs that cause or that can be used to treat LV remodeling should be almost all of our pillars, in fact, all that can be used. The first line antihypertensive that cannot be used or that does not have any benefits, that is just for symptomatic relief, will be the loop diuretics. Every other medications that we use will actually reverse remodeling. So we should take note of that for the sake of MCQ. Then the other class that may not be applicable in that sense would be those that will cause vasodilatation as part of the newer class of drugs, but every other one will really. Sacubitril is still the RAS system. You understand? The DAPA will also do it. Studies have shown that it has reverse remodeling capability. So we should just note that in case we are managing. So almost in the yes, he has explained the remodeling and the different circumstances where we can have them. However, we should also note that in real life or in real time, it's possible that you have two different pathologies in a patient. So, like we know the normal natural history for AR, for instance, now, it's that the left ventricle will be huge, will be big, will have eccentric LVH normally because of the regurgitation, and also for MR, we should have eccentric LVH from LV IDD, increased LV IDD. We get that, which should give an eccentric LVH. But if in the same patient there's background hypertension, the patient has had hypertrophy, do you get? It's possible that you have the chambers dilated, but it's still hypertrophied. Do you understand? Does not really give the thinning out or the stretching out that you see for eccentric LVH. Maybe that's what he's trying to explain by getting right, which occurs in real life. When you have him of a long-standing hypertension, it's possible that you see that the walls are thick. Do you get? However, the LVIDD is increased. So those are the times that we might not be able to say exactly that this is a type of remodeling that you have in the patients. So saying one predominates than the other might mean that patients had already developed a complication of one of the two pathologies. And of course, it's possible to have eccentric hypertensive heart disease too. So depending on what's actually, so you really cannot say. So that's where the list comes in. So I hope we got that. Thank you for.
Thank you, Chief. I appreciate it. Thank you very much.
Okay, thank you so much, Chief Maladi. Okay, so move over to the next okay, I think Prof is here. Okay, good evening, Prof. Okay, we'll move over to the next presenter, Dr. Bassi.
Good evening. My question is number 10, and it reads, what are the key processes in heart failure pathophysiology that predispose to arrhythmia? Now, the mechanism of cardiac arrhythmia include automaticity, triggered activity and re-entry. And heart failure is associated with structural, electrophysiological, and neurological remodeling. And the other speaker has really spoken at length on remodeling. Now, although genetic arrhythmias often occur in structurally normal hearts, most of the cardiac arrhythmias like atrial fibrillation, ventricular fibrillation occur primarily in diseased hearts. And therefore, cardiac remodeling associated with heart disease, especially heart failure, plays an important role in cardiac arrhythmogenesis. Now, the remodeling in diseased hearts, like the other speakers mentioned, includes structural remodeling, even electrophysiological neural innervation of the innervation, that's or the protein. I will go for that. Common structural heart failure. Now block, leading to continuous generation of reentral tachycardia. And this, we all know that this causes arrhythmia. Now, atrial fibrosis in the atrium is a major substrate for atrial fibrillation. And when you have fibrosis in the atrium, it actually decreases impulse propagation. and promoting re-entry, and this facilitates the development of atrial fibrillation. Now, fibroblasts are associated with the global myocardial response to mechanical, electrical, and chemical signals. And fibroblasts modulate conduction, and they promote cardiac automaticity and triggered activity by that is the process of depolarization. And this fibroblast remodeling may actually be a new component of atrial fibrillation related remodeling that contributes to arrhythmogenic dynamics. Now, to go to electrophysiological remodeling is also important in arrhythmogenesis. And a reduction in the potassium current. You remember the action potential. So when you have a reduction in the potassium current, this significantly increases the incidence of delayed after depolarization, and this induces triggered activity and leads to arrhythmias. Now, when you have spontaneous, you have the sarcoplasmic reticulum, you have spontaneous calcium release in the sarcoplasmic reticulum. This will activate another current called this calcium and this one will now reach the threshold and give rise to spontaneous action potentials, which is generally referred to as triggered activity. Now, both myocardial infarction and heart failure can result in significant reduction in this potassium current. Can lead to, another one is myocardial infarction and heart failure can result to a reduction in potassium current. The mechanism of potassium current relate to the calcium, elevated calcium current, that is influx. Now, let me just go back to what I've said. One of the mechanisms of heart failure, that's the mechanism by which heart failure causes arrhythmia. I mentioned the potassium current downregulation. The second one was the sodium upregulated, that is the increased sodium calcium exchange current. And then another one is this heart failure can also be increased, be associated with increased inward sodium current, reduced repolarization reserve, and is actually pro-arrhythmic. And it's also associated with diastolic dysfunction in a failing heart. Another modality is if in remodeled hearts, you can have complete heart block, and this complete heart block can lead to QT prolongation, and this QT prolongation will downregulate the delayed rectifier potassium current, and this helps to reduce repolarization, and it promotes arrhythmias in diseased heart. And then you can have cardiac nerve sprouting, which is very interesting. That is when you're in heart failure, in heart failure, even if you have that you have like other tributaries, you have cardiac nerve sprouting, and is an additional remodeling of the autonomic nervous system in diseased hearts, like heart failure. And the mechanism of this nerve sprouting is actually not known. Catecholamines, that is increased catecholamine level in the heart, will lead to nerve increased nerve sprouting. And you know, when you have increased cardiac sympathetic outflow, corrections, and so on. I actually found it in
Okay, Dr. Baxi, I can't hear you again, but okay, I think the last time I heard you, I think you had concluded. Okay, thank you so much for your presentation. Okay, so the floor is open to questions and contributions.
Hello, Dr. Bassi. Thank you very much. I don't know, am I audible?
You're distant.
All right. All right, thank you very much. Is it better now?
Yes, a lot.
All right. Dr. Bassi, is it possible for you to this heart failure and arrhythmogenesis, for you to tabulate it like 1, 2, 3, this does this, this does this, this does that. So it's actually very interesting as we listen to you now. A kind of maybe flow chart or something. Am I even audible, sir? All right, thank you.
Okay, Prof, you can have the floor. Prof, thank you.
Okay, good evening, everyone.
Good evening, sir.
Yes, thank you. I just want to bring something to the attention of the team or the group. That is the most important phase of the exam. And this is, I guess, the questions we are treating now are questions for the Osce. I mean, the Viva segment, right?
Yes, sir.
Okay, so it's important to know that for this exam, 50% of the mark is Viva, 50% is MCQ. So irrespective of what you get in the MCQ, the best place to get a real mark is in this Viva. One important thing is that for the Viva, they need the candidates presenting need to be as concise, as specific as much as possible, tailored to the questions and how the exam will flow. For each of the steps on the Viva, you have 10 minutes. So it means that any information you are giving to the candidates here must be as accurate as possible. That will summarize whatever you are explaining in 10 minutes. So I beg you in the name of God, just make sure that every information is well packaged. For a candidate to be asking that, can you tabulate it, give an algorithm, is trying to make you understand that all this information has to be concise for the exam. Please, this is where the real exam actually, this is the 50% of the exam. and it's like all the preparation you have been making towards the MCQ with all 50%. The real is these few days left, which is the 50% you are using to dissolve this Viva station. Thank you very much.
Thank you, sir. Dr. Passy.
Yes, yes. Sorry, I was logged out. I didn't. Yes.
Okay, Dr. Cyril, please can you ask her your question? I think she wasn't there when you asked the question.
Yes, thank you, Dr. Bassey.
Okay. Yes.
I was just requesting if it would be possible for you to just
Okay. Okay. Okay.
I don't know. Chief Arumalade, please, you have any contributions? Oh, and Chief Adeyanju. Okay, Chief Arumalade, Dr. Arumalade is not on the call right now. Okay, so Dr. Bassi. Hello, Dr.
Yes.
Bassi. Okay, maybe
Yes.
what you
Yes.
do, maybe much later, you can send it to the group, like what Dr. Cyril said, like in a way that it's like self-explanatory. Like you just send it to the page. You get now, right?
Okay.
Okay, thank
All
you
right.
so much. Thank you, well appreciated. Okay, thank you. All right, so move over to the next presenter, Dr. Conte, to take number 11. Dr. Suri.
Yes, I hope I have a stable network. The network has been misbehaving this evening.
Sorry, sir.
So the stem there is systemic causes of pulmonary hypertension. So, okay, I'll just go through, the conditions that are classified based on the current 2020 guidelines as systemic causes of pulmonary hypertension. So to start with, pulmonary hypertension is defined based on hemodynamic assessment of right heart catheterization. And that definition is as a mean pulmonary arterial systolic pressure greater than 20 millimeters of mercury at rest. Okay. So it is important to know that though the hemodynamic definition is the central part of the definition, but however, in the final diagnosis and characterization of pulmonary hypertension, and you need to be sure that the whole clinical context of the patient is taken into consideration, and any further tests or investigations that the patient has done must also be taken into consideration when classifying the patient as to what group of pulmonary hypertension they belong to. So based on the, talking briefly about the classification, so pulmonary hypertension is classified into 5 groups, okay? So group 1 is the pulmonary arterial hypertension, okay? And under pulmonary arterial hypertension, you have several subtypes under it. So you have the idiopathic form, the heritable form, those associated with drugs and toxins, those associated with connective tissue disease, associated with HIV, portal hypertension, and even congenital heart disease, all fall under group 1. It will also be important to note that there are some conditions that were previously under group 5, but in the most recent guideline, they were brought under group 1. conditions like the HIV, schistosomiasis, portal hypertension. Okay. So the group 2 is the pulmonary hypertension associated with left heart disease. So any condition that cause left heart failure, increase left atrial pressure, can cause pulmonary hypertension, usually described as a post-capillary pulmonary hypertension. Okay. And then for the group 3, there are conditions that are associated with lung diseases or hypoxia. Okay. So there are several conditions under that. And then group 4 are the conditions that are associated with pulmonary artery obstruction, okay, or pulmonary occlusive disease. All right. And then group 5 finally is the group wherein you have pulmonary hypertension arising from unclear or multifactorial mechanisms. Okay. And now under this group, you have 6 subclasses under this group 5 that are due to unclear or multifactorial mechanisms. Okay. So the first one are pulmonary hypertension due to hematologic disorders. Okay. And then the second group is pulmonary hypertension due to systemic disorders. Okay. And with this recent guideline, there are 3 conditions that are listed under the pulmonary hypertension due to systemic disorder. And those conditions are sarcoidosis, okay, and neurofibromatosis type 1, okay, and pulmonary Langerhans cell histiocytosis. So I'll go over that again. So for the current classification, the things that are classified under systemic causes of pulmonary hypertension and under group 5 are the sarcoidosis, okay, the neurofibromatosis type 1, and pulmonary Langerhans cell histiocytosis, okay. Still under the group 5 pulmonary hypertension, you also have conditions with metabolic disorders like your glycogen storage diseases. You have chronic renal failure, pulmonary tumor, thrombotic microangiopathy, and fibrosis mediastinitis. So all these are under group 5. So going to the question that was asked as a systemic causes of pulmonary hypertension, based on the current classification, then we talk about sarcoidosis, pulmonary hypertension sarcoidosis in neurofibromatosis type 1 and pulmonary Langerhans cell histiocytosis. So for sarcoidosis, we all know it's a granulomatous, it's a systemic granulomatous inflammatory condition. So most commonly the lungs that are affected, but any other organs in the body can be affected. So in patients with sarcoidosis, about 6 to 20% of them develop pulmonary hypertension. Okay, and like the group that they are classified under is pulmonary hypertension due to unclear or multifactorial mechanisms. So for sarcoidosis, the mechanisms are really multifactorial, and several mechanisms have been proposed. Okay, so one of the causes is that because of the associated fibrosis in the lung that can lead to pulmonary hypertension. Also, granulomas in the pulmonary arteries or pulmonary veins can also contribute to pulmonary hypertension. The fibrosis in the mediastinum associated with the condition can also contribute. Okay, and even because with sarcoidosis, one of the cardinal findings is mediastinal lymphadenopathy. Okay, that mediastinal lymphadenopathy can produce obstruction to the pulmonary arteries, and that can also be a mechanism of pulmonary hypertension. Okay, also vasculitis of the pulmonary arterial system in sarcoidosis also contribute. And then people with pulmonary with sarcoidosis are also have increased occurrence of thromboembolism. So they can also have CTEPH. Okay, so they can have group 4 pulmonary hypertension as part of the mechanism causing pulmonary hypertension in sarcoidosis. Okay, so when patients with sarcoid have pulmonary hypertension, it's really associated with significant morbidity and mortality. Okay, and in small studies on non-randomized studies, they've shown that when these patients are treated with medication that are used to treat pulmonary arterial hypertension, that is 1 pulmonary hypertension. Okay, they tend to have short-term improvement in their hemodynamics. Okay, so if you do catheterization, you might notice some drop in the pulmonary pressure. Okay, but however, they've noted that it does not improve their functional capacity. So they've objectively subject them to 6-minute walk test on these medications, and taking the medication, even though some hemodynamic improvement occur, but their 6-minute walk test does not seem to improve. And also those who have active inflammatory disease, they've shown that steroids and other immunosuppressants may help improve, the hemodynamics if they have concomitant pulmonary hypertension. But again, this one does not improve their functional capacity, and it has not been shown to improve mortality. So despite use of pulmonary medications for pulmonary arterial hypertension, the long-term survival of patients who have sarcoidosis and develop pulmonary hypertension is still very, very poor. So that's is the reason for the recommendation that people who have sarcoidosis and pulmonary hypertension, you should consider them for a lung transplant. That is the only thing that will improve their survival. But otherwise, even with the medications for pulmonary arterial hypertension, their prognosis is still very poor. Okay. For neurofibromatosis type 1, it is actually rare in patients with neurofibromatosis, but when it does occur, it is associated with significant morbidity and mortality. Okay, and people who have neurofibromatosis, we tend to see pulmonary hypertension more in the female population than male. So a 3.9:1 ratio exists for those with neurofibromatosis when they develop pulmonary hypertension. Okay, the mechanism for pulmonary hypertension in neurofibromatosis is not well understood. But however, they've noticed that neurofibromatosis patients have been found to have pulmonary vascular involvement. So there is some vasculitis happening in the pulmonary circulation that is thought to contribute to the pulmonary hypertension. Okay. And also in this group, the use of the medications for pulmonary arterial hypertension, so your endothelin inhibitor, the
30 seconds.
prostaglandins, they've all not been shown to improve prognosis at all. Okay. For the pulmonary Langerhans cell histiocytosis, this is a rare condition, okay, and primarily the condition affects the lung parenchyma, so they tend to have ventilatory limitations due to the primary disease itself. But however, they've observed that the decreased exercise capacity that you see in this patient is not commensurate with the ventilation problem. Okay, it occurs more as a result of the pulmonary hypertension. Okay, and when these patients are put on medication for pulmonary arterial hypertension, it actually tends to improve their function, okay, without worsening their ventilatory limitation. But however, in this case also, the prognosis is not improved at all. Okay. So basically for these systemic conditions, when you have sarcoidosis, neurofibromatosis type 1, and pulmonary Langerhans cell histiocytosis, when you have concomitant pulmonary hypertension in this condition, the patient's morbidity is worsening, and also they have increased mortality. And so far, the medications that are available to treat primary pulmonary arterial hypertension have not been shown to improve their mortality. So the option that remains for them is lung transplant. Thank you.
Thank you so much, Dr. Conte, for taking your presentation. Okay, so Dr. Conte, so in essence, I just want to get So when they're talking about this question, so what they are being centered on is sarcoidosis, neurofibromatosis type 2, and then the pulmonary Langerhans cell cystocytosis.
Yes, based on the current classification of pulmonary hypertension.
Okay. All right. So for the sarcoidosis, the treatment, okay, so you said is steroids, the non-biologics.
Yes,
right?
anti-inflammatory when they have active inflammatory disease, because the inflammation the mediastinal inflammation, the lymph nodes all contribute to the pulmonary hypertension. So when you treat the active inflammation, it tends to improve their hemodynamics. But however, it does not significantly improve their outcome as far as the pulmonary hypertension is concerned.
Okay, so if all of these do not suffice, is there any other thing, any other option? If the medical therapy doesn't suffice?
Lung transplant.
Okay, thank you.
Yeah.
Then the neurofibromatosis. Okay, one. Okay, so how does it cause pulmonary hypertension? I didn't get that, sorry for taking it back.
Okay, so it is associated with vasculitis, specifically in the pulmonary vasculature. So that is it is not well understood. So the vasculitis is the mechanism that has been proposed as the cause of the pulmonary hypertension.
Okay, thank you. Then the Langerhans cells cystocytosis, is it still via inflammation, or what exactly?
Yes, so they tend to have more long parenchymal inflammation, and they tend to present more with a sort of restrictive type of lung disease. And then they have limitation in their ventilatory capacity. So their vital capacity go down. Okay. And clinically, they have reduced oxygenation of the blood. But however, when they do develop pulmonary hypertension, it is the pulmonary hypertension that actually worsen their outcome, reduce their exercise tolerance, not necessarily the hypoventilation problem that they have. Okay. And here also, they've noted that it's not the hypoventilation that caused the pulmonary hypertension. The mechanism for the pulmonary hypertension is not known.
Okay, thank you. Thank you. Okay, so the room is open to questions and contributions. Okay, so if none from the participants, I would like to move over to our chiefs. Chief Alison, Chief Adeyanju.
I don't think I have any comments with these questions being well discussed so as to save our time. Thank you, Dr. Conte, for your discussion.
Okay, and Prof. Sir.
So okay. Important thing is to note that I hope you know the definition as changed, and I would expect that the candidate would also have discussed how the class, apart from the physiological classification, also the classification based on hemodynamics, pre-capillary, post-capillary.
Okay, Prof. Well noted.
Yeah. Okay. Great.
Thank you so much, sir. So I'll move over to the next question. This thing is always going off my page. All right. Okay. Dr. Ojo.
Yes, Dr. Foreign, good evening.
Yeah, good evening, sir. Now, please have the floor.
Okay. Thank you very much. I don't know if Chief Conte can, because the question involved me protecting some pictures. So, if we can share, so that I can share our screen.
Yeah, hello, Dr. Ojo, I did not get what you were saying.
I said if you can share so that I can share my screen. My question involved me projecting some pictures.
All right.
Okay, good evening, teachers, facilitators, good evening, my colleagues. I just want to talk briefly on the question that I talked about the picture of ASD and also atrial fibrillation. So, just a brief introduction. ASD is a congenital cardiac disorder caused by a spontaneous malformation of the atrial septum. The intra-atrial septum formation actually starts from the end of the 4th week, and this is just a picture that shows what happens. We know that from the primitive 5-chamber heart, when we label from top, from bronchoarteriosus, robust cordis, primitive ventricle, primitive atrium, and the sinus venosus down. So we have the end, these two ends, is the base, then towards down here we have the atrioventricular canal, and the common atrium actually, the septum is formed between the common atrium to separate the two atriums. So from this picture now, the first projection we can see is the septum primum, which actually grows from the roof of the common atrium and coming towards the septum intermedium in the center to close that defect. Now, it's when it goes down, since in utero, there should be a communication between the right side and the left side. So it does not fully close. So leaving this opening, which is the ostium primum. This is where my cursor is. So as it grows, it also continues to grow downward until now complete to fuse with the septum intermedium here. And since, as I said, there should be a continuous communication between the right side and the left side, so there is a degeneration in the septum primum. So that degeneration in the septum primum creates another opening, which is the ostium secundum on the septum primum, so that through that opening the communication will continue. So just after that there's now a formation of another septum with the second septum, with the septum secundum, just on the right side of the septum primum, which also grows downwards. Now, the projection of this septum secundum downwards leave an opening between the septum secundum and the septum primum. This opening is called the foramen ovale, where, as we know, the oxygenated blood that is coming from the umbilical vein is projected towards, and that forms a connection between the right side and the left side in utero. So the possibility of the different types of septal defect is the first one that I mentioned, the ostium primum, which is actually supposed to close. If it doesn't close, it can leave that defect, which is the septum primum ASD. Now, also the second one is this opening, the septum secundum ASD, in which in utero you expect the opening to close, and if it doesn't close, so that's the second type of ASD. Then the foramen ovale, and fourth one is the sinus venosus ASD and coronary sinus defect. So that's 4 types of ASD: ostium primum, ostium secundum, and sinus venosus and coronary sinus ASD. Talking about the epidemiology, ASD account for 10% of all the congenital disease, and we know that the commonest is the ostium secundum ASD, which accounts for 75% of cases, and we know that ASD is actually commoner in female, ratio of 2:1. We also know that for primum septum primum ASD, there could also be other congenital defects associated, like the cleft mitral valve, the inlet ventricular septal defect, and that combination is known as the partial V septal defect. This is just a picture showing the septum primum ASD, and this other one is showing the sinus venosus, which is actually the defect is eye up there, the sinus venosus ASD. This one shows the secondum ASD. I mentioned this already. The sinus venosus ASD, it's actually a defect in the represent abnormality in the insertion of the superior and inferior vena cava, which overrides the intertidal septum, which is the intertidal communication is then formed within the mouth of the overriding vein and outside the area of the fossa ovalis. And it will also be associated with some other congenital anomalies like the partial anomalous drainage of the right inferior pulmonary vein. This is just a echo picture that shows the BSD. You can see from this one, this is a coastal view that is inverted, which the atrium are now open. We can see the color flow and the communication between the right atrium and the left atrium through the ASD. And also, this is also a fourth chamber that's also inverted, and you can see that communication there between the right atrium and the left atrium. And also here at the short axis view, you can see the communication here also. And in this one, you can see that the right atrium is also looking similarly enlarged. And because we know that the communication is actually from the left atrium to the right atrium, until the right atrial chamber will increase and the pressure will increase. And if it increases for a long time, a seminal syndrome can develop in which there will now be reversal of flow. Clinical features could usually asymptomatic, but when they become symptomatic in childhood, they can present with easy fatigability, recurrent respiratory infections, dyspnea or palpitation. Physical examination, you can see features of the right-sided enlargement, pulmonary hypertension, but very important is that here is a known cause of a wide split second heart sound, wide split S2. The murmur is a mean-systolic pulmonary ejection murmur, which results from the increased blood flow across the pulmonary valve, and it represents the moderate to large left to right shunt. Talking about investigations, ECG, depending on what we are doing, either primary ASD or the deviation and the RBBB and secondum type. Majorly, we want to examine the patient to see patient have features of that we need indication for intervention, which will include the size and location, the magnitude of hemodynamic compromise, and if there is pulmonary hypertension, and the options of closure involve either a device closure, especially for the secondum ASD, which we know that is the secondum ASD that we can close by device, and other types of ASD will involve surgery. So that's just the general overview of atrial septal defects. Going to the second question that I talked about, atrial fibrillation. Atrial fibrillation, as we all know, is the commonest sustained arrhythmia in medical practice. It's one of the very common arrhythmias, and by the time we have ECG that want to suggest AF, want to look at ECG for the features, which will include presence of fibrillary waves. We'll see that the KI complex or the RR interval will be regular, as you can see in this picture. And also the KI complex, most of the time is narrow, except if there's now maybe some other thing out there, maybe there's a excitation, AF in the setting of excitation, or AF with maybe a premature ventricular complex. That's when you see a wide complex. But on the normal, the complex in normal AF should actually be narrow, and also the so irregular RR interval, fibrillary waves, narrow KI complex. Those are the ECG features of atrial fibrillation. And of course, we know that by the time we make that diagnosis, we have to manage the patient by multidisciplinary approach to management, in which we want to assess the patient ventricular response to see if how to manage this patient. Also very important is to assess the patient for presence of features of hemodynamic instability, which will actually also determine how we manage. Risk factors include things like common things like heart failure, hypertension, pulmonary embolism, even to alcohol, obstructive sleep apnea, even type 2 DM, ischemic disease. Those are the common causes, common risk factors. We should also not forget thyroid disease. Thyroid is also a very important risk factor. It can occur post intervention, maybe post surgery. Also, chest infection like pneumonia can actually predispose to atrial fibrillation. So, in managing a patient with atrial fibrillation from the newest ESC guideline, we want to look at the patient holistically and follow the CARE approach. The C is the looking for the comorbidities that I've already mentioned. It should be noted that all these comorbidities should be managed because that will actually prevent the progression of the atrial fibrillation. So, we want to look for hypertension, look for heart failure, look for type 2 DM, look for alcohol, look for obstructive sleep apnea. So all these comorbidities should be managed. Then the A is to the CARE. So the A is to assess for the R is to do a rate and rhythm control, while the E is the to evaluate the patient to educate the patient on the risk for the atrial fibrillation and also to give the patient informed consent to determine which form of anticoagulant to choose. The A is actually to assess for risk for thromboembolism, which we want to use what we commonly use is CADVAS score, but now from the newest guideline is now a CADVAS score in which which you want to use CADVAS score to actually assess the patient for risk for thromboembolism, which the CADVAS score is 2 and above. So sex cardio is not used again. So if the CADVAS score is 2, you want to place this patient on anticoagulant. And if it is 1, you may want to consider anticoagulant if there are presence of other features like obesity, renal disease, or when the left atrial dimension is elevated and the left atrial volume is elevated. When the CADVAS score is 1, in the presence of all these other factors, you want to consider anticoagulation, even the CADVAS score is 1. The anticoagulation of choice should also, from the guideline, depend on the cause of the atrial fibrillation. If the atrial fibrillation is setting of prosthetic cardiac valves or severe mitral stenosis, the drug of choice is warfarin. But for other types of atrial fibrillation, the non-vitamin K anticoagulants have been seen to be the drug of choice in those instances. Treatment could be rate control or rhythm control, in which patients that present in acute setting, you want to choose rate control. Also, different terms of rhythm control include use of cardioversion, especially for patients that are in hemodynamic compromise, and also to put this patient on cardioversion could be electrical cardioversion or chemical cardioversion, to put or use medications like flecainide or amiodarone. Also, catheter ablation is also a very important form of rhythm control in selected AF patients, especially those ones that are in heart failure, in which we know that presently now catheter ablation has earned a class 1A recommendation for the treatment of atrial fibrillation. Other thing is to do a continuous monitoring of this patient, to continue to monitor them and to reassess them for their risk factors and to see if their rate is well controlled. So those are the just a general overview of atrial fibrillation. Thank you.
Okay, thank you so much, Dr. Ojo, for taking your part. Okay, so the floor is open to questions. Okay, and contributions. Okay, Dr. Ojo, you said that the CADVAS score, if it is 1 and there's presence of obesity, I didn't get the other ones, please, sorry.
Yes, if the CADVAS score is 1 and you now look out for other risk factors for AF that are not included in the CADVAS score, These risk factors include obesity, CKD, patient that has a high left atrial dimension more than 4.7, patient that have a high left atrial volume index. So when the score is 1, in the setting of this other risk factor, the patient will benefit from anticoagulation.
Thank you. So,
thank you, Dr. Ojo, for the presentation. Okay, please, I just wanted to ask about looking at the acyanotic and congenital heart disease, ASD, which you just talked about. Assuming one is given probably oxygen saturation in some parts of the heart and then some pressure. For example, oxygen saturation in the IVC, the right atrium, right ventricle, pulmonary artery, pulmonary left ventricle, and aorta, and the pressure. How can we interpret such to actually be able to make a diagnosis of probably either an ASD, which you just talked about, or possibly probably a ventricular septal defect? I don't know whether you got my question.
Yes, I got your question. Thank you. Now, talking about using the oxygen saturation at different segments of the heart to know if there is a shunt or not. Yes, for atrial septal defect, we know that the site of this shunt is in the atrium, and as we said, it will be a left to right shunt. We know that on the right side of the left side of the heart, we have the oxygenated blood, and on the right side of the heart is the deoxygenated blood. So when you now take the oxygen saturation, possibly in the IVC or in the SVC, though we know that the oxygen saturation in the IVC is actually higher than that from the SVC, because we know that the oxygen usage of the brain is actually dependent on oxygen. So this oxygen saturation in the SVC is actually a little bit higher than that of the SVC is actually lower than that of the IVC. So by the time you take the saturation either in the SVC or IVC, and you now compare with the saturation in the right atrium. So if for example, just an hypothetical case, maybe you take saturation in the IVC, it's maybe 70%, for example, and you're not taking in the right atrium, maybe towards the middle portion or the lower parts of the right atrium, and you're not getting something like 85, for example. So you can say that in that kind of situation, that there is a wide difference in that of the saturation from the IVC and the lower part of the right atrium. So it means that there is actually a communication between the left side and the right side of the heart, with more oxygenated blood coming from the left side to increase the oxygen content in that right atrium. So that may be a pointer to a possibility of a right of atrial septal defect. So for the ventricular septal defect, what you do is also compare the saturation in the atrium, then the ventricle, and also look at the saturation in the pulmonary artery. So normally the saturation in the pulmonary artery and that of the ventricle should also be similar, except there's a communication between the left side and the right side of the heart. So when you look at those saturation and you see a very steep, a very wide gradient in the saturation, it will be a pointer to a possibility of a communication between the left side and the right side of the heart. I don't know if you have me to answer the question.
Thank you.
Okay, so we'll move over to our chiefs, Chief Orimolade and Chief Adeyan.
Sorry, Florence, just quick one. So,
Okay.
it will be important, discussing atrial fibrillation, to mention that, before now, we were working with the AFFIRM trial that shows no significant difference in outcome if you go for rhythm control strategy or rate control strategy in patients with chronic AF. But recent evidence from ESTAFNET study have demonstrated that early rhythm strategy in patients who have had recent onset AF and they have no structural heart disease is actually superior to rate control, okay, in terms of outcomes. So that we should take note of that. Thank you.
Dr. Conte, we can't hear you again.
Oh, my network. Where did you lose me?
I can even barely hear. Just continue.
So I was mentioning that you should mention the East AFNet that actually showed early reading strategy to be superior to rate control in people who have without structural heart disease and have recent onset atrial fibrillation. And I think for in the new guideline, they've included that if the onset of the AF is within a year, okay, and the patient does not have significant structural heart disease, give him control actually as a class 1 recommendation.
Thank you. Thank you, Dr. Conte. Okay, so, okay.
Please, what's the name of the trial, please?
East AFNet, East Atrial Fibrillation Network. So it's East AFNet.
Thank you.
Compared to the AFNet trial, like it was being followed now, and is it for any patient, irrespective of age or symptoms and risk factors?
Dr. Neka, you're far away. No, we can't hear you. You're distant. Okay. I think she's having a network challenge. Okay, so we'll move over to our Chief Alison and Chief Adeyanju.
Yes, thank you. Thank you so much, Dr. Hojo, for those slides. Thank you for the efforts. Well appreciated. Just to add that with the just because we discussed mixed that's the oxygen saturation in acyanotic disease. So that's why. So also be good to mention that you have to calculate the QPQS2. That's the shunt, that's the ratio. And the significant one, we understand that indicates surgery will be one that is greater than any shunt that is greater than 1.5 is actually significant. And we should also note how it's calculated, not only for ASD, also for PDA. And we should know how we can calculate it and the various views that we need. So we need the short axis view where we look at depending if it's PDA, we need the short axis view. What we just need to calculate is the RVOT VTI, the RVOT diameter, then we'll also do the LVOT VTI, LVOT diameter. Then we get so the first one I mentioned will be the pulmonary circulation, then the other one will be for the systemic circulation, and we generate the ratio to calculate if it's significant or not. They can also ask us in MCQ. They'll give us the values or give us the tracing for the measurements. So we should be able to calculate that. It's quite important too, just like the mixture that Dr. Lalikon was talking about. We've gone through the guidelines for atrial fibrillation, so I don't think we should overstress that. Thank you so much, Dr. Oden.
Okay.
Thank you, Chief. Thank you.
Thank you, Dr. Ojo, for the pictorial presentation. I think I just noted some things that I should call all our attention to. In embryology, let's try to use the right terminology. So Dr. Ojo, you were trying to remember, I don't know whether it's apoptosis or programmed cell death. So try and use the right terminology. So let's start saying it now so that when it is in exam, it will be at our spinal level. Then apart from that, I think it will be good if you've mentioned some, I think there are proteins or some proteins that are involved when there is arrest in the pathophysiology of ASD or VSD. I think there are some proteins that are involved. I can't remember everything about. There is GATA4. There is, I think, NKX25. There are about 5. So if we can put that one as part of our discussion, it will also be good rather than leaving it out. When there is mutation in those proteins, it's also it affects the development of the osteum, whether it's the septum premium or secundum. Then the whole they're talking about is fenestration from programmed cell death. And I think that you should also, maybe I missed it, but you should mention when those growths of the septum, when it actually ends. I remember 7th week, but we can check that week up. I think it's 7th week that there is supposed to be a halt in the growth of the septum secundum. Then we should note that before the septum premium, before it elongates to join the endocardial cushion, that apoptosis is already occurring in the upper pole, forming fenestration in the upper pole. And I like the fact that you mentioned that the septum secundum arises from the right side, because they might actually twist that one and bring it out in the MCQ. So those are the things I noted from the embryology. Then apart from that, I think we should actually try and remember ASD and some syndromes in case if they said I should mention some syndromes with ASD, Down syndrome, Oram, Ehlers, and some other ones. So maybe we should just know about 5 just in case. Then you can also ask ASD and pregnancy, or if you have more time during oral discussion, you've not finished your discussion, and you can also put that one at the tail end if you are stuck of what to say. Then they are asking about ASD and AFA. I think they might also bring out ASD and infective endocarditis, which is also high yield. I think that we'll be able to navigate that if that comes out. So those are just the things I noted that I thought I should mention. Thank you very much for your discussion. Thanks.
Thank you so much, Chief Adeyanju and Chief Remolade for your contributions. Okay, I would like to move over to Prof. Prof, sir.
Okay, good presentation. Thank you. Great. It's open for you.
Yes, sir, you are.
The question on the ECG, was it different from that of the ASD or of the recall? Because I was expecting that the delegate would actually discuss the ECG finding in ASD. So I don't know, maybe that was how the oral question is. ECG of the calculation of this scenario of ASD.
Sir, we can't really hear you. Sorry, sir.
We're trying to talk about the ECG that came after the discussion of the ASD. Hope I'm audible.
Yes, you are, sir.
So in the station, was it that there was a question on ASD, then the next sub question was on atrial fibrillation? Or you are discussing ECG finding in ASD?
Dr. Ojo, okay.
Yes. Thank you, Professor. The way, I'm not sure if you recall issue or something, but the way the question is being framed, look as if the ASD picture is different from the ECG picture. So like A and B. So that's why I put it
Okay, sure, no problem, no problem. So, but it's important to know the ECG findings in the different types of ASD. Okay, so then maybe I missed it, the different types of ASD. And when you were discussing, you said the treatment for ASD, yes, there is surgical and there is device closure. But you know that also in sinus venosus, you can do both surgery, and there's also room for those that don't want to do surgery. They can also do an intervention. You can actually put a stent to cover the sinus venosus. Well, it's a new method of what they do for those that don't want to do surgery. Okay, so but what the important information you just need is to know the ECG patterns in the different types of ASD. Hope you understand, sir.
Okay. Yes, sir.
So yeah, so it's these ECG patterns are very important for the different types of ASD. And it's also be good to know why they are this way. It's very important. So you won't cram it into the hole. You have to know why is this ECG for like this in this condition and that like. Yeah. So you should know for second why should you write axis deviation? For what should be left axis deviation? There's a reason for all those things. So don't cram.
Thank you, sir.
Thank you, sir. So, for the different types of the ASD, so I mentioned the septum primum, the septum secundum, the coronary sinus ASD, and the sinus venosus ASD. So then for the ECG changes for primum ASD, it tends to have a more of left axis deviation as opposed to the secondum ASD that will have right axis deviation. So other things that have also been seen on ECG include the right bundle branch block pattern that we can see in the secondum ASD.
Two important information. The sinus venosus ASD, right? So the superior is into the inferior vena cava ASD. Okay. Number 3 is when you are discussing the ECG finding, we are asking you why is it left axis for this condition? Why is it right axis? There's a reason for them. So for the condom, you are telling us now, why do they have a right axis? Why not a left axis of the condom?
I have to take that. I'm not sure. I'm not sure.
Or else the candidate will cram it into the hole. That's what we're saying. And the reason is straightforward. What kind of shunt direction will you naturally see in secondum ASD?
In secondum ASD, it's left to right shunt.
Why? So if you have a left to right shunt, so what do you think will happen on the right side?
There will be increase on the chamber and dilatation of the right atriums.
So there'll be RV overload, right?
Yes, yes, sir.
There to now. That's the same reason why they have a right bundle branch block. And that's the same reason why they want right target division. Because of the RV overload. You get that, sir?
Yes, sir.
So why do they have a left axis?
I was thinking maybe it's the same left to right, because it's this cyanotic method.
So the same flow direction can give you two different types of axes. If it's the same left, why should it be left? Why should you have axis division in the left right chunks or secondum, and you're now having left axis division in the same left right shunt for diamond? It shouldn't be the same. Okay, so one important thing you should know is that in common USD, remember, is a form of AV canal defect, called a partial AV canal defect, right?
Yes, sir.
And one of the canal defects is that, especially the partial AV canal defect, is that they have mitral paths. So most times, most of those patients will have MR, severe MR. Okay. So the MR will cause the left side to dilate. Okay, so that is one of the reasons why the left axis will be. You just need to. It is very important for you to remember that the same physiology goes for sinus venosus CSD. The sinus venosus CSD. Remember the of either the IVC or the SVC is straddling over the roof of the entire receptor of the receptor.
Sorry, sir, I didn't hear you, sir.
Oh, yeah. Is it the sinus venosus?
Yes, sir, the sinus venosus.
If you look at sinus venosus CSD very well, the superior vena cava, let's talk about the SVC type. The superior vena cava is straddling over the roof of the entire septum. If you see the echo very well, it's sitting, SVC is supposed to be committed just to the right atrium, right?
Yes, sir.
When there is not the defect at the roof of the entire septum, the SVC is now straddling. That means sitting over is sitting on the roof of that entire septum. So it's pouring blood both into the right and to the left side. You get that, sir?
Yes, sir.
So the increased volume that is shared to the left side will give you that left axis division. If you get it, sir.
Thank you, sir.
Just remember that it is about the volume that changes the axis, because it's going to change the chamber size, and that's what will change the axis.
Thank you, sir.
Okay, thank you so much, sir. Thank you, our chiefs, for your contributions. We appreciate. All right, thank you, Dr. Ojo, for your presentation. Okay, so the next person on the chat is Dr. Zakia. Dr. Ojo, please, can you share your slide? Dr. Ojo, please, can you share your slide? Thank you. Dr. Conte. Okay, thank you. Okay, so Dr. Zakia, you can please have the floor to take number 13.
Okay, good evening. Good evening, Professor. Good evening, class and mass. So I'll be taking question 13, adrenergic receptor blocker. So adrenergic receptor blockers, they are also known as adrenergic receptor antagonists. They are drugs that they act by binding to adrenergic receptors, either the alpha or beta receptors, thereby blocking the responses that are normally produced by catecholamines, or blocking the responses that sympathomimetics produce. So based on this classification, the classification depends on the type of receptor which is blocked. We have the alpha blockers and then the beta blockers. So for the alpha blockers, we have alpha 1 and alpha 2. So the alpha blockers are further classified based on their selectivity. So we have the alpha 1 selective blockers, and then alpha 2 selective blockers, and then the non-selective alpha blockers. So for the non-selective alpha blockers, they block both alpha 1 and alpha 2 receptors. And then we've discussed in our previous, in a previous question, alpha 1 receptors are found in most vascular smooth muscles, leading to vasoconstriction. They are also seen in the prostate, leading to contraction. They are seen in the heart. They increase the force of contractility of the heart. And then on the skin, smooth muscle of the skin, they lead to erection of the hair on the skin surface. They are also seen on the pupillary muscles, where they cause dilatation of the pupil. So blocking alpha receptors will mean we are blocking this effect. So alpha 1 blockade will lead to inhibition of vasoconstriction. So it will cause vasodilatation in both arteries and veins, thereby leading to decrease in peripheral vascular resistance, decrease in blood pressure, and venodilatation, due to vasodilatation of the veins too. So they can also, the decrease in blood pressure effect that is produced by the alpha blocker depend on the degree of the sympathetic tone. And that's why they most often cause orthostatic hypotension. So